So the VISION HOVON-141 trial is a trial for relapsed refractory CLL, and obviously now present the 5-year follow-up, meaning that most of the patients who have been treated in that trial actually received chemoimmunotherapy in the frontline setting. Thus, for what we have in terms of relapsed refractory CLL trials at the moment, we have this limit that we cannot inform or do not know yet if we can use the same relapse treatment after frontline treatment with the BCL2 inhibitor or BTK inhibitor. Thus, this is an open question. What we can say from this trial is that we can do something new in terms of how to individualize treatment, because it's the first trial in CLL where we used minimal residual disease, MRD, to guide treatment decisions. It's a Phase II trial. All patients received 15 cycles of ibrutinib venetoclax combination treatment, and the patients who achieved undetectable MRD levels after these 15 cycles were randomized 1:2 between ibrutinib maintenance or observation with MRD testing every 3 months. Thus, we took what we've seen in chronic myelogenous leukemia, CML, where you can stop tyrosine kinase inhibitors and follow patients if they achieve a deep molecular response, and restart treatment upon molecular relapse before the patient had a clinical relapse. So that was essentially the research question. And now we have more than 5 years of follow-up for the patients in the VISION HOVON-141 trial. And it's feasible to stop treatment for patients who become MRD undetectable and restart treatment based on regular MRD testing. We've demonstrated that after 5 years, 40% of the patients had to reinitiate treatment, and among those patients who reinitiated treatment, we only had 1 progression. On the other hand, we also saw that just a little more than 40% of the patients reinitiating treatment, they actually achieved undetectable MRD levels again. So it does not mean that we can stop and get all the patients back upon progression molecular relapse and stop treatment again. Thus, if the patient have a molecular relapse, we reinitiate treatment for 12 months with a combination of venetoclax-ibrutinib, and then we continue ibrutinib monotherapy. And that is probably needed. In terms of understanding the sequencing of treatment, this gives us some information as well, because the reinitiation of treatment for the patients with a molecular relapse before they have a clinical relapse is actually testing whether the combination of ibrutinib venetoclax can be used again. And seeing that we achieved a new remission and only 1 of the 19 patients, 5%, having a progression, and for a little less than half of the patients we actually achieved undetectable MRD again, it indicates that it's feasible also to retreat with this combination. The other question would be, is it needed to stop treatment? Would it actually be preferred from patients to just stay on a BTK inhibitor indefinitely? And there are 2 caveats about that. One is, in this trial, in the VISION HOVON-141 trial, we looked for adverse event burden during treatment in the arm randomized to ibrutinib monotherapy or maintenance, and in the observation arm. And we see less adverse events reported during observation, even though we reported and follow up for adverse events in the same way in the 2 arms. The other thing is, from real-world data, we have seen that the median time to discontinuation outside clinical trials on a BTK inhibitor is 3 years. So it's not indefinite treatment. Patients or clinicians outside clinical trials and within clinical trials, the median time to discontinuation is 7 years. Outside clinical trials, patients and physicians are not trained good enough or not willing to continue treatment that long. And thus, we need to figure out how can we make time-defined treatment for patients with CLL.